Huhn, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's CMEO briefcase entitled Switching Antiretroviral Therapy, ART, in Your African American Patients, When and How. Today's program is supported by an educational grant from Gilead Sciences, and I'm the COVID-19 Vaccination Coordinator and Senior Director of HIV Services at Cook County Health. I'm an associate professor, Department of Internal Medicine in the Division of Infectious Diseases at Rush University Medical Center in Chicago. Our learning objective for today is to integrate best practices for switching ART in patients based on efficacy and safety data. So let's start with a case. Jeffrey is a 31-year-old African-American male who was infected with HIV perinatally. As a child, he was intermittently engaged in HIV care and treated with antiretroviral therapy. His grandmother was his guardian and caregiver, and following her death, he was in and out of foster care, which impacted access to care and adherence to ART. So in early childhood, he initiated AZT monotherapy, then lamivudine was added for dual nuke therapy and RTI. Nalfenavir was then added as a PI at age 7. At approximately the same time, HIV viral load testing was approved, and the patient had a variable viral load profile from undetectable to 200 to 400 copies for several years. Later, he switched off nalfenavir to lopinavir ritonavir for easier dosing and tolerability. And then at age 16, he switched to a single tablet, Favirenz emtricitabine tenofovir disoproxil fumarate, or TDF. This was better tolerated than the PI, and he does well for 2 years. Then he experienced inconsistent adherence due to depression coupled with vivid dreams, which really never completely went away, which led to virologic failure with a viral load of approximately 4,500. So we have resistance testing upon re-engagement. This is a genotype test with mutations K103N for a non-nuke, the M184V, signature mutation against emtricitabine and lamivudine, as well as a 210W and L, 210W and a K219Q as TAM mutation. So he has multi-class resistance, and upon re-engagement, he was started on elvitegravir, cobicistat, emtricitabine, TDF, plus darunavir, and eventually transitioned to elvitegravir, cobicistat, emtricitabine, and then the updated tenofovir is tenofovir alafenamide, plus darunavir. So now Jeffrey's currently maintained on elvitegravir, cobicistat, emtricitabine, TAF, and darunavir with virologic suppression. So let's take a look at our interaction with Jeffrey during this virtual visit. Hi, Jeffrey. Nice to see you today. How are you doing?
Hi, Dr. Huhn. Nice to see you too. I'm doing great, thanks. I started a new job at a tech company doing web development, and I gotta say, I'm liking it so far.
Hey, that's great to hear. You know, I got your labs and everything looks good. The viral load, the CD4 count, right where we want them to be. Anything you want to share about your health in general?
Nothing from a side effects perspective, but I have to say, I feel like I've always taken pills, lots of pills. And I would just like to get back down to taking one pill like I used to when I was a teenager. I hate to upset the apple cart, but man, it would be nice to simplify things.
And now for our audience response polling. Should further resistance testing be done? Yes, no, or I'm not sure. And at this point, this is a proposed stable switch. So Jeffrey's undetectable, he's virologically suppressed. So I don't really find a role for resistance test of proviral DNA at this point. We already know what his resistance test profile was from that genotypic test upon re-engagement. And so what we want to do now, no further genotype testing is needed. We want to take into these factors before considering switches and to simplify therapy. So we want to certainly review the patient's full treatment history. This is critical before initiating a treatment switch. So any history of multiple virologic failures or pre-treatment drug resistance, we want to make sure that we have an inventory of those mutations, review the cumulative resistance test results, and know about the clinical response to prior regimens. Jeffrey did switch prior regimens. He did get undetectable for a time. And then we actually know about the multi-class resistance now that he has prior to re-engaging in care. And we want to know about any tolerance, intolerance, toxicities, or adverse events. And we know initially to the Favirenz emtricitabine, the tenofovir disoproxil fumarate, the TDF, that there was those vivid dreams, there was some depression. So we really want to really have that in our back pocket, and to know that we're going to potentially switch him on a regimen that's not going to really play into where he would currently need to worry about that sort of tolerability. We want to review active medications, including herbal supplements, over-the-counter medications for drug-drug interactions, and particularly for these integrase inhibitors, perhaps any of these divalent cations, any calcium supplements, magnesium, things that could affect the absorption of those integrase inhibitors. And then certainly always consider the patient preference. And here, Jeffrey really wants to go back to one pill once a day. So let's take a look now at how we further that conversation now with Jeffrey about the potential for stable switch. Yeah, I get that. Let's dig a little deeper to see what our options are. You know, a few years ago, you struggled with an episode of depression that impacted adherence. So I want to be sure that we're thinking about that, factoring that in. Is your depression being managed right now?
For about a year, I was taking escitalopram, but I'm not taking anything now, and I'm doing well. I think having a steady job is very important.
All right, well, good, you know, because adherence is really where we need to be. So we've talked about it in the past, and the adherence part, it's super important for a lot of reasons. Obviously, to maintain an undetectable viral load, but we always have to be cognizant of resistance patterns.
Yeah, and I know that's actually why I brought that up today, because even taking a couple of pills just seems like a lot. And I don't want to run into a resistance issue.
Yeah, okay. Well, good. I'm glad we're having this conversation. So you've had some resistance from your previous regimens when your adherence just wasn't where it should have been. And as we've discussed in the past, so we just need to be aware and factor that into our decisions. So bottom line, yes, we have some options.
Okay, great. Let's talk about them.
And our next question here is, to which antiretroviral agent or agents would you choose to switch Jeffrey? So let's take a look at some recent data that really can inform our decision as to what would be the preferred regimen to switch Jeffrey to, and as well factoring in what Jeffrey really wants to actually get out of his new regimen. So Dawning was the data first released in 2017, and this was really a very important trial. Maybe did not rise to the level of awareness, certainly here, maybe in the US, because this was in a resource limited setting, but it really does tell us now in the modern era with the second generation integrase inhibitors, really the potency of these integrase inhibitors with background nuke regimens. And so this was looking at patients that had failed a regimen that had 2 nukes in the background. Most of these failures were with efavirenz. And so these were first-line failures, and the patients were randomized 1-to-1 to receive either dolutegravir with 2 nukes that were chosen by the provider based upon what they felt was going to be the most active 2 nukes, and then randomized to the PI, lopinavir, ritonavir, again with what were to be regarded as the most potent 2 nukes. Not all resistance testing was available at that time of the switch. So it was really by provider informed preference what those 2 nukes were going to be. And we see here at 48 weeks that this was a superiority was met with dolutegravir plus those 2 nukes at 84% versus 70% with the lopinavir ritonavir arm with the 2 nukes. This study was actually stopped early because of this superiority. And it really supports now dolutegravir as a second generation integrase inhibitor with these 2 nukes. And it suggests that maybe just one fully active nuke combined with dolutegravir would be highly effective, because there were a majority of the patients actually coming into this trial that were randomized that had nuke resistance, that had M184V. And we can see with the 2 best nukes that you could probably choose from, that maybe only one of those would be active, and the dolutegravir, the integrase inhibitor, really carried the regimen toward virologic suppression. So very important trial, second generation integrase inhibitors with probably 1 active nuke that could then really lead the way toward virologic suppression in those first-line failures. And we see here in the licensing trial, one of the licensing trials actually for bictegravir, the single tablet regimen, bictegravir, emtricitabine, and TAF. These were patients that were being switched off a virologically suppressed FTAF with dolutegravir and randomized to either continue that regimen or switch to the single tablet regimen, bictegravir, emtricitabine, TAF. And we see here that there are very high rates of virologic maintenance of suppression at 48 weeks, 93% in the what we call BIC FTAF versus 91% in the dolutegravir FTAF arm. And this was a non-inferior type endpoint, and so pretty much equally worked well. And it just says that if you're going to make this switch off dolutegravir and FTAF, that single tablet regimen, bictegravir, emtricitabine, TAF, will likewise maintain virologic suppression. And so as a summary slide, patients can safely switch from dolutegravir to either FTAF or FTDF to a single tablet regimen of bictegravir, emtricitabine, or TAF. Actually, in that trial, patients could either be on dolutegravir with the two versions of tenofovir, FTAF or FTDF, the original tenofovir. So this virologic suppression was maintained regardless of resistance to nukes or prior history of treatment failure. So at baseline, 25% had nuke resistance to either prior virologic failure or treatment with a non-suppressive single or dual nuke based therapy. And again, going in though, they were virologically suppressed. It was a stable switch. And so this may be of interest. BFTAF, BIC FTAF may be of interest to older adults or those with cardiovascular risk factors. Again, the protease inhibitor containing regimens may be associated with higher lipid levels or increased risk for cardiovascular events. And as well, we've seen some of that data with potential increased cardiovascular risk with recent use of abacavir. So now we look to the BRAVE study. And so background for BRAVE, within these licensing trials for bictegravir, emtricitabine, and TAF, 26% of those participants were Black or African American. And so here we wanted to have the representation now in a standalone trial for bictegravir, emtricitabine, TAF among African Americans. So this is a randomized, open label, active controlled phase 3 trial that evaluated a switch from, and again, this is a stable switch, 2 nukes with a third agent, to bictegravir FTAF, so single tablet regimen among Black persons living with HIV. We can see here a very good denominator or sample size going in with 495. A majority were already on FTAF as a nuke backbone, 67%, 19% were on FTDF, and then 14% were on abacavir 3TC. And that third agent was really mostly integrase inhibitors, 59%, but also 29% non-nuke, 6% PI, and 6% other. We see here actually that there were cases of past resistance to nukes, balanced in both of the randomized, actually it was 2-to-1 randomization, BIC FTAF to continuing their baseline regimen, 13% versus 16% for the baseline nuke resistance. High degree of non-nuke resistance, not surprising, a lower barrier to resistance in the first generation non-nukes, 21% versus 19%. And then PI resistance, 11% versus 15% in the baseline regimens. But we see here again for the 24-week data that patients overall maintain their virologic suppression regardless of whether they had M184V in the background. And in fact, there was really no difference for those, whether they continued their regimen, which was already suppressive, versus if they switched to BIC FTAF. And again, these virologic suppression rates are 95% and above, which we would expect with the performance characteristics of the single tablet regimen, second generation bictegravir with FTAF. And again, we see here now at 72 weeks that we now have durability from the 24-week time point. This was just recently presented at IAS in July. There was, at 24 weeks, then patients then could switch over if they continued on their baseline regimen, could switch then the single tablet regimen bictegravir FTAF. So this is a delayed switch, and we see there that we really had 99 to 100% virologic suppression even after that delayed switch to the single tablet regimen BIC FTAF. No treatment emergent resistance was detected in any treatment group. So in this large group, African Americans now, we see that that maintenance in a stable switch strategy to bictegravir FTAF, regardless of let's say an M184V in the background from prior treatment failures, this maintained virologic suppression in these patients. So when we look at stable switch, what are the drivers for stable switch? What are the reasons? And we look at optimizing this ART regimen for our patients. So certainly managing or preventing any short-term or long-term adverse events. Patients that come in with higher pill burdens, we saw this with Jeffrey. He just wanted to get down to that single tablet regimen. Higher pill burden versus anything beyond once daily dosing, let's say BID dosing. Get it down to once a day. Pregnancy, difficulties with any food or fluid requirements or restrictions. Again, to prevent or mitigate drug-drug interactions to minimize those potential DDIs, and then actually to reduce cost as well. So let's take a look at some of the data then when it comes to stable switch options for bictegravir FTAF. So in the GS 380, 1878, this is a stable switch from a boosted PI from 2 nukes. And again, that N, we want that N to be around 500, 577. All participants who switched off the PI and the 2 nukes to bictegravir FTAF had sustained virologic suppression. We see here, this is coming off of at least 2 pills onto a single tablet regimen. Now, taking a look from one single tablet regimen to another, dolutegravir, abacavir, 3TC, switched to bictegravir FTC, FTAF. This is the GS 380 1844 study. And again, so patients, they were stably going in, virologically suppressed on dolutegravir, abacavir, 3TC. After 1-to-1 randomization for 48 weeks, non-inferior switching to BIC FTAF to maintaining the dolutegravir, abacavir, 3TC. So another trial demonstrating non-inferiority, which we would expect for our patients. They're virologically suppressed, but they're coming in, switching to BIC FTAF, maintaining virologic suppression. And then finally, the GS 380 1961 trial, where patients, these were non-pregnant women with HIV, virologically suppressed on elvitegravir, cobicistat, emtricitabine with either TAF or TDF, and randomized to switch to BIC FTAF. And this again was non-inferior. So we see very consistent findings, non-inferiority, maintenance of virologic suppression, and a stable switch coming off a previous regimen that may be multi-pill or dolutegravir based or elvitegravir based onto BIC FTAF, showing non-inferiority with maintenance of virologic suppression. Let's take a look then more closely at dolutegravir and some of the switch strategies, particularly to these 2-drug regimens. So, and that was one of the options we had in the polling question. So Tango was a stable switch where patients were stable on a TAF-based regimen, and it was either a 3-drug or a 4-drug regimen. And then they were switched, again, randomized 1-to-1 to dolutegravir 3TC, so a 2-drug regimen. And after 48 weeks, this performed well. So the dolutegravir 3TC, this was non-inferior to maintaining virologic suppression versus those continuing on their TAF-based suppressive regimen. But importantly, there are some key exclusion criteria. So any history of a major nucleoside reverse transcriptase inhibitor or NUC or integrase inhibitor mutation, and they were excluded. So that would exclude those with a history of, let's say, of an M184V. Striving was a switch where they were suppressed on 2 nukes and a 3rd agent, and then they were randomized to switch to abacavir, dolutegravir 3TC. So this is the single tablet regimen with dolutegravir 3TC and abacavir. And again, this was a delayed switch strategy, 1-to-1 randomization. And then finally, at 24 weeks, all participants had the opportunity to switch to abacavir, dolutegravir 3TC. And this again was non-inferior, met non-inferiority at 48 weeks, where those that were switched to abacavir, dolutegravir 3TC, 3-drug regimen, they were virologically suppressed to the same degree as continuing on their 3rd agent plus the 2 nukes. And then finally, the SWORD trial. So this is the 2-drug regimen, dolutegravir, rilpivirine. Again, one of the options we had for Jeffrey in the potential options for switching. And these were patients that were virologically suppressed on a 1st-line or 2nd-line ART regimen. The 3rd agent was any 3rd agent, and whether it's a PI or an integrase inhibitor, a non-nuke, and then plus the 2 nukes. Now, importantly, again, this is a 2-drug regimen, so we need to be careful. Key exclusion criteria: any major resistance-associated protease inhibitor, integrase inhibitor, nuke or non-nuke mutations, or the integrase resistance-associated substitution, the R263K. Those are exclusions. So again, we would have those patients that if they had an M184V in their background would be excluded from this type of switch strategy. But at 48 weeks, those that were virologically suppressed made the switch to the 2-drug regimen, dolutegravir, rilpivirine. That was non-inferior to continuing on their current suppressive therapy. And finally, we have doravirine as the switch option, which we saw in one of the polling questions. So these were patients that were virologically suppressed on 2 nukes and either a boosted PI, elvitegravir, cobicistat, or a non-nuke, and they were randomized, larger trial, 670, switched to the single tablet regimen, doravirine, 3TC, so lamivudine, and TDF. So this isn't TAP, but this is TDF. And again, we see here 48 weeks non-inferior, those switched to the single tablet regimen, doravirine, 3TC, TDF. They did as well virologic suppression versus those that stayed on their current suppressive regimen. And also this was associated with a more favorable lipid profile compared to those coming off of a boosted protease inhibitor. So doravirine, TDF, probably, again, what we know is more lipid friendly. So again, we're revisiting now. Now we have our options, we have our data, and this is where we have our follow-up conversation with Jeffrey to really come to an understanding of what it's going to take with this switch to maintain that virologic suppression. All right, so we're going to make the switch now. We're going to bring it down to 1 pill once a day, a little bit of an update from what you took when you were a teenager. It's called bictegravir, emtricitabine, tenofovir, elafenamide. I know it's a big name, but again, still importantly, 1 pill once a day. We'll need to have some more frequent visits just in the beginning so that we can monitor things a little bit more closely.
That's not a problem, not at all. What are we looking out for in particular? CD4 cell count, viral suppression, usual side effects?
Yeah, really, it's exactly those things. And I don't expect anything, but anytime you start a new regimen, we just need to keep our antenna up.
Okay, is there a rule of thumb about how to go about monitoring?
Well, we do have some guidelines, and we'll be talking about those.
What do the guidelines say?
And coming off that conversation, we talked about guidelines. So these are the DHHS guidelines for monitoring after a regimen switch. And here's our polling question then. And so here, the correct answer actually is C, monitor patients within 3 months after that switch. My practice, I like to touch base with the patient probably sooner than that, at least get a viral load probably in about 4 to 6 weeks, especially in somebody like Jeffrey, who's had some adherence problems, has had some past resistance. So I really want to know if that switch is really maintaining that undetectable viral load, and just to see how he's tolerating it. So, but by DHHS guidelines, we monitor within 3 months. Again, for tolerability, virologic suppression, adherence, and then safety. And then again, we need to really look for any potential side effects, particularly when we're starting a new regimen. So as follow-up after the switch, Jeffrey is, again, as we talked about, he switched to bictegravir, emtricitabine, TAF. You know, I made the call after 2 weeks, and he's taken his pill daily without any tolerance issues. He comes back to clinic in 1 month, the viral load's obtained, and he has virologic suppression. Again, not surprising coming off of his multi-pill regimen, but now we know with the studies that we've seen, certainly in Striving, we saw that in Brave, history of M184V, just with bictegravir FTAF itself, that should maintain that virologic suppression. And, you know, our goal here is really for these self-assessment tools and self-motivation tools for our patients, it is really looking at the SMART factors. So these need to be specific, measurable, attainable, relevant, and time-bound. And so somebody, you know, where we've had a conversation with patients like Jeffrey, we want to make sure that these are realistic goals in a certain time frame for taking their pill once a day, for making sure that they're tolerating it well, that they're not missing any doses, That really fits into their lifestyle. So when we take a look at a patient's full treatment history, their drug resistance in the past, any tolerability issues, active drug list, we need to account for that in making that switch. Patient factors, very important. Most of my patients do want to be on once daily pills. If they're taking, again, pills, there are now going to be developments of even other types of delivery methods rather than just oral pills. But for right now, most of our data is with these daily oral regimens. And so when you're making that switch, you need to have that shared decision making with the patient for their preferences. The high pill burdens, the dosing frequencies, these can certainly impact adherence. And so when you look at your SMART goals, you say when you're coming off these high pill burden type regimens, what are measurable and specific goals, and are these attainable? And certainly for most patients, they are. And then finally, again, we want to monitor those patients after the switch for, again, those tolerability, virologic suppression, and adherence by the DHHS guidelines. All right, well, we had our first briefcase, and we have 2 more to follow. So briefcase 2 from CMEO is the pediatric patient with HIV translating data into practice. And then our third briefcase is going to be prior treatment failure and addressing the challenge in HIV care. And again, we can find these programs at cmeoutfitters.com/ID hub. And then don't forget to complete the post-test and the evaluation. And then you can download your certificate or your CME certificate from the website. So again, thank you.